Hello, and welcome to today's webinar. My name is Daniel Castro, and I'm Vice President of the Information Technology and Innovation Foundation. The topic we're exploring today is telehealth, both the recent changes we've seen in telehealth policy in response to COVID-19, as well as its prospects once the pandemic is over. So joining me today are three excellent panelists. We have Angela Fusaro, co-founder and CEO of Physician 360, a telehealth provider, and Mon Johnson, the CEO of the American Telemedicine Association, and Mei Wang Kwang, the Executive Director of the Center for Connected Health Policy. So thanks to all three of you for joining us today. Before we begin, just a quick note about logistics. You are welcome to ask questions of the panelists at any time during the event. If you're watching on ITIF.org, you can use the Q&A form under the video. If you're watching on YouTube, then follow the link in the event description. So to begin, I want to talk about where we are today with telehealth services. What's striking to me is that all these various types of telehealth services have been with us for a while. I think I did my first online consult about 5 years ago. But at the time, that was really seen as kind of a luxury service. It wasn't paid for by my insurance. I had to pay out of pocket. And it's not something that is very common, even though it was so much more convenient to do this. But what we've seen is that, of course, with the COVID-19 pandemic, this has taken off both in terms of the demand and the supply side. So what I'd like to do is start off by discussing where the policy is today. This is obviously a fast-moving area, but maybe you can kick us off with this. Can you just kind of briefly describe the steps the administration's taken, Congress has taken, and some of the states are taking to enable telehealth in response to COVID-19?
Thank you, Daniel. Sure. As you mentioned, it's been pretty fast moving and a lot of action has happened both on the federal and state level. So pre-COVID-19, a lot of the existing policies directly related to telehealth really did center around reimbursement, what you were touching upon, what was paid and what wasn't paid. And on the federal level, a lot of that centered around Medicare. What we've seen over the last couple of weeks is essentially the administration or Congress removing a lot of those barriers within Medicare for the usage of telehealth. And there's two things that you have to understand. The barriers in Medicare, a lot of those were actually embedded in federal law, which is why we needed to see Congress act before some of those issues could be removed. And there were some administrative changes that CMS could make, which they've also been doing as well. The major ones, at least in Medicare, have been removing the barriers that are related to the location of the patient, the services that are reimbursed, as well as the not necessarily the modality, but expanding some of the ways in which you can use telehealth as far as how it's being delivered. And who's delivering it. So what we saw were removal of the geographic limitation, the location of the patient as far as site, allowing the home to be an eligible site, as well as expanding who can provide the services. A big shift was allowing federally qualified health centers and rural health clinics to be eligible providers to provide services. And they've expanded the list of services that they would cover if the service was delivered via telehealth. They haven't really touched the modality issue yet, so it's still essentially live video if you are talking about telehealth, but also keep in mind the way Medicare reimburses for technology delivered services, they essentially have two buckets. The telehealth bucket, which is restricted a lot of times by what's in federal law, and then another bucket called technology enabled services or communication based services that do utilize telehealth technologies as well as the phone, which aren't considered telehealth by CMS, but use those technologies to deliver services. So there's these two sort of buckets that they have in which a provider can deliver services through technology to the patient, but they're not necessarily treated in the same way. So those are kind of the broad strokes of what has been done in Medicare. The other thing that we have to keep in mind for where federal policy is concerned, or some of the changes have been related to other issues that touch upon telehealth, such as prescribing. So underneath federal law, they essentially control how controlled substances are prescribed, and there's narrow exceptions in how you can use telehealth before an in-person, if an in-person visit has not occurred between the telehealth provider and the patient. And one of those exceptions was if a public health emergency has been declared, which it has been, so that exception is kicked in. But they've also expanded the use of the phone to prescribe if it is for treatment of opioid use disorder, and if you are prescribing buprenorphine, if certain certain parameters are met. So that was another change that we've seen as well that impacts telehealth. I know there have been questions about licensing as well, and that's related to like how the Medicare policy looks at that. Licensing is really within the state domain and how that is regulated for the most part. Another issue in which the feds have also relaxed things a little bit is around Hipaa and the privacy issues as well. They have said that the OCR will not be fining and will give a little bit of leeway in how people are treating Hipaa when they're going through this particular public health emergency. On the state level, we're seeing them mirroring some of the federal changes as far as like the areas that they are making changes in with telehealth policy. And again, that's location, types of services they're expanding, and type of providers that they're allowing. And it varies from state to state. Pre-COVID-19, each state was in a different position as to where their telehealth policies were, with some who had pretty expansive policies and others who had more narrow policies. And what we're seeing though is some of the most common type of changes that they're making is allowing the home to be an eligible originating site, allowing the phone to be used because policymakers are recognizing not everybody has access to the technology. So the phone may be the only way in which to reach those people who are staying at home and still needing services, and possibly expanding the list of providers who are eligible to provide services to. So that's kind of in the nutshell, sort of like the areas that we're seeing a lot of policy changes, really the areas where there had been limitations before COVID-19.
Thanks for that. And you know, you're looking at this for a while, obviously seeing the changes that's happening in the industry. And part of this, you know, part of the question has always been about whether providers will adopt the technology. And, you know, FCC obviously now has funding available to providers. Are you seeing a strong demand in, you know, the healthcare providers moving in this direction, and what kind of questions are they wrestling with?
So I think that, first of all, I want to commend May for her mastery of everything that's happening. It's great to be on a panel with you, May. So thank you for all the oversight you provide. The issue of the providers, I think that we've seen a couple of things. One is that there has been a general acknowledgement that the idea of keeping people safe, you know, practice social distancing is really important. And so providers have really seen how virtual services can be adopted or engaged with their patients to keep them safe and away from the home, from the office, the physician's office. The second area is, I think, the whole use of using technology, virtual services to engage patients who are sick, who have chronic conditions, who need to be followed and managed. So we've seen a real uptake in that as well. We are obviously very interested when we hear from providers who talk about their practice converting to virtual literally over a weekend, and had a panel yesterday of a number of practitioners from the West Coast and the East Coast who really went through, within a 36-hour, 48-hour period, just flipped to virtual almost immediately. And what they're seeing then is that with the right engagement with their patients, that they're able to keep them going. People are generally very pleased to hear from their physician. They may have thought that the practice was closed. And so they're very happy to engage with them. And then the other issue we're seeing now is a lot of innovation going on with, for example, pediatricians who are working to make sure that their patient population, their kids, continue to get well child exams and continue with vaccines. So obviously you can't do a vaccine virtually, but there are ways that you can triage people pre-coming in for vaccinations. We're seeing setups in parking lots and so forth, drive-through vaccines going through as well. So I would say that while the uptake has been pretty significant, it's been really nicely dispersed between managing people who have to stay at home for one reason or another, as well as continuing to engage patients on an ongoing basis.
Thank you. And Angela, I mean, you know, some providers are trying to do this now overnight, as Ann said, but others have been doing this, of course, for quite a while, like yourself. You know, I would love to hear kind of your take. Just, you know, you're seeing so many people kind of come to start using telehealth, which is what you've been advocating, for a while as, a very viable option. You've seen how it works. You've, been working on making it scalable and effective for specific conditions. What's your kind of opinion of the state of where we are right now?
Sure. I mean, yes, I love that we have been trendsetters. I think, as you alluded to earlier, something that was a luxury, it was very peripheral or supplemental to healthcare, has now become really the focus of what people are seeing as the viable first step in many things, not just coronavirus, but beyond. We've definitely seen an uptick in adoption, both as it directly relates to screenings for COVID-19, for accessing testing options for COVID-19, but then for really any other condition that you otherwise would have gone in person for. I think one thing as a provider myself, so I'm an emergency medicine physician, and although I don't practice a lot anymore, I do hear from my clinical colleagues that it's tough to prepare for what is immediately in front of you with a support level that is substantial. There's been a lot of, as both of the other panelists have alluded to, state and federal level support for making that transition now. But I think one of the concerns is, will the policy follow in the longer term? And so if you've made these transitions to help support us through what is a public health crisis, when that crisis normalizes and we find ourselves in the quote unquote new normal, will the policy still support the providers who really rallied and tried to make that transition quickly? And so that is definitely a concern that I've heard from my clinical colleagues.
Thank you. And if I can stay with you for a moment, I mean, one of the questions I think patients have and others who are trying to understand the role of telehealth, both now and going forward, is really how viable is it as an alternative to in-person care? To what extent should patients be using this on a normal basis in the future, even when we're outside of a pandemic?
Sure. I think the answer to that really is telemedicine is very viable. I mean, I honestly, obviously, think that it will be the epicenter of how care is provided going forward. I do think that there are certain disease processes, certain conditions that will always fall outside of, at least in the immediate future, the reach of telemedicine. But I really think it's about being open to adapting with the speed that the technology is evolving. And so while in this current moment, maybe there's, a few very, again, specific scenarios where I'm like, I don't totally see telemedicine playing a role there. They're, number one, the minority of cases, because I do think it can play a very relevant role for the overwhelming majority of conditions. But even those fringe cases where it might not be relevant today, technology is evolving so quickly that in 2 months that might be obsolete, and maybe they would become relevant then. So I think it's really about a mindset of innovation of, let's continuously reevaluate the role it can play. Let's try and purposely put it on the forefront for all of the reasons that it has become clear during coronavirus. Telemedicine is valuable. That's going to be the case going forward. It's a prime way to achieve cost containment. It's safer. We can, it's more functional in resource limited areas like rural health. And so I think it's really about a mindset. The technology itself is 100% viable and will continue to play a more expanding role. And we just have to mentally continue to support that.
Daniel, can I just add on that for a second? My experience, again, within the ATA and the membership, as we have a number of special interest groups that are very clinically focused, they have, for example, the group that's focused on behavioral health, they came out with practice guidelines 2 years ago that were endorsed by the American Psychiatric Association. And the headline of those practice guidelines was that virtual is as good, if not better, than face-to-face, which is really important because, to Angela's point about access, if you look at behavioral health services, pre-COVID, 1 out of 5 Americans were having a mental health issue or would have a mental health issue, as well as over 50% of counties in the US not having any sort of mental health services available to their population. So this is really technology that can be used to great advantage across a lot of different specialties. And again, you're seeing with, for example, dermatology, it's been used for over 2 decades and quite frankly has been very exacting and impactful in diagnosis of different skin conditions. You've seen it in a number of different specialties. And so to Angela's point, I think we are seeing a uptake and a greater acceptance, and in fact, greater surprise among many clinicians as to how adaptable they can be and how useful the technology can be.
Daniel, I
And
think the problem we've had is that the technology develops at such a rapid rate that, at least on the policy end, it just hasn't been able to keep up with it. And really, the one thing that CCHP has always said regarding the policy around telehealth is that really it should be broad enough that it allows the provider to decide when and where telehealth should be used, because they are the ones who are treating the patient. They are the one with medical knowledge, and they know if it's appropriate for that particular situation. And pre-COVID-19, I think we may have started seeing the beginnings of some of the policy being pushed that way. The California Medicaid program, they actually updated their telehealth policies last summer. So they were actually in a pretty good position pre-COVID-19 going into this pandemic. And one of the policy changes they made, a major policy change, was essentially we're allowing the provider to decide whether they want to use live video or store and forward to provide a service that Medicaid covers, and we will pay for it as long as it meets these certain qualifications, such as there's not like an in-person requirement that they needed to do to perform the service, and that it's a service that the program actually covers. So that type of broad flexibility in a program, I think, really helps not only advance telehealth, but it really leaves it to the right person in making the decision in whether to use telehealth or not. And that is the provider who is there with that patient during that specific time. Because you could have a condition that, you know, is totally fine to use telehealth for, say, like diagnosis of a skin condition, and it's totally fine to use telehealth, but it may not be appropriate for one patient where it's appropriate for another. But really, the provider should be the one making the judgment call on that.
that's a really excellent point. I mean, I think when we look at the technology adoption of physicians and hospitals, I mean, we've seen that it sometimes lags. You know, we've done work looking at electronic health records and other types of health IT systems, e-prescribing. You always want providers to be the ones making the decision, but you also want to make sure they can actually be making the decision, that they're telehealth enabled, right? That they have the technology in place. So I guess I have two questions that I want to put out there. One is, you know, to what extent, you know, are providers going to be telehealth enabled coming out of the pandemic? And, you know, the second question is, you know, really related to the fact that we do see, you know, after clinicians try it, a lot of them like it, and they're going to want to continue to use it. After patients try it, they like it and want to continue to reuse it. I guess my question is on the policy side, you know, after the policymakers do some of these interim changes, are they going to say, okay, this is something that we want to now enable going forward? Are they also liking it and wanting to move forward?
I think there will probably be some things that they will want to keep. So to let folks be aware, most of these changes that we're seeing, practically all of them, they're just temporary. So we're not quite sure. There's an expiration date on them, whether there's an actual physical date that a policymaker has put on there, or when the public health emergency is over. But I think there is a recognition that telehealth did play a major role in not only addressing the pandemic, but also in like how our healthcare system operates and how care is delivered. And they're going to want to keep some of these things around. One thing that I think has been missing pre-COVID-19 from the discussion and from some of the push for telehealth was actually on that consumer end. I've been doing this for about 10 years, and even before COVID-19, I think I still have family and friends who didn't quite understand what I did for a living. So the average person who's not involved in healthcare or in policy may not understand what telehealth is, or knew that it existed out there. But now really the consumers are getting like a crash course in telehealth. And I think you'll hear like an outcry if suddenly it goes away once the public health emergency is over. And I think policymakers will listen to that, and that also be something that they'll take in consideration in like their future actions in allowing telehealth to continue on without some of these barriers that existed pre-COVID-19.
Yeah, I think that's a really good point, May, in terms of people pre-COVID thinking of telehealth as a convenience factor, and now really it's a matter of life and death in many instances and in many communities. And people don't even appreciate how pervasive telehealth in all its forms has been. So just the idea of using asynchronous tools, chat first, interactive assessments with consumers that help them understand whether or not their symptoms are related to COVID or not. Those were tools that were put in place rapidly to help delivery systems in particular scale their response. I mean, that they literally handled tens of thousands of inquiries on a very, very short-term basis. So that has been really incredible to see.
I was just going to add, I think, May, that we'll also see the same cultural shift, not just from the consumer, but from the provider. And so hopefully in combination, you now have providers who had a variety of things to be advocating about through their own, professional organizations. I think telehealth has now probably risen to the top of that list. And so that in combination with, again, the financial support you're going to see like coming out of the CARES Act. And I think it will be this perfect intersection of a real turning point for the industry.
Mm-hmm. For a lot of providers, telehealth has actually been a lifeline for them for keeping their business afloat.
Mm-hmm.
So that's another thing that I'm a telehealth resource center, so we get a lot of calls from providers of like, how do I get started? And they've essentially have told us is like, my business is going to go over. I'm just like a solo practitioner, or we have a small practice. We need telehealth because we're not earning money. So I think they've shifted them. They've shifted that group.
We've also seen, though, that, and we've been very focused, as I'm sure you have also, May, on encouraging providers who are just getting started to make sure they still do it right. So we're very focused on providing tools and resources so they know which platforms and which companies are putting forward HIPAA compliant tools, for example, and encouraging them to use that, because although there is some discretionary easement that's been provided, as May referenced, the reality is that there is a tension between the federal level and various state and third-party agreements that we have to respect and acknowledge. So, just making sure, just because we're moving fast doesn't mean we get to cut corners.
Yeah, I'd like to stay on that point because I think that comes up again and again. Last week, we had a conversation about the move to online learning and the fact that, so many teachers are, basically being stuck in front of a camera and said, here, teach, and, you're connected, just figure it out. And so, I would imagine there's that same dynamic for some providers where, now, yes, they're connected, but the question is, well, how do you do this effectively? How do we make sure that there's not diagnostic mistakes, that we, don't start creating new problems, that we think through these issues? Angela, I mean, so, you've practiced both in person and online. What are the differences there? I mean, what should, providers be thinking through? And, should there be separate, training or certification in this area? What should we be thinking about long term?
Sure. I mean, I think like with anything, there's obviously a learning curve. It is not directly comparing apples to apples. So, I am, strongly in support of there being an emphasis on practicing medicine through telehealth for that exact reason. I think it's something that some medical schools and residency programs have, very proactively before coronavirus started to initiate. I think that after the pandemic, it will be something that most, curriculum leaders will really take a look at, as far as there should at least be some degree of module learning around this. I will say that, the practice of medicine is, it's an art and a science, but the way that we practice in the United States in specific, because we are a developed country, we have access in many places, I wouldn't say most, but in many places, to laboratory testing, to radiographic evidence. We're accustomed to relying less on let's say the overt physical exam. I think in some ways that makes the transition to telehealth a little bit easier. I also think that the peripherals that are being developed right now for telehealth are closer and closer approximating being able to perform the same physical exam that you would be able to achieve in person. And so while I think, again, with anything, there's a learning curve, I think we are well positioned to ascend that learning curve quicker than maybe some other communities. I think as far as what providers should be thinking about, it's not even just necessarily how do you learn to practice practice medicine through telehealth. I think there's other operational decisions that go into that. And so even to what Anne said before you really dive in, I think there's just some operational considerations of like exactly what role is telehealth going to play, what types of, what part of my patient population is best positioned to be treated through telehealth. I think thinking through the operational parts of it in conjunction with how can you physically practice, the medical aspects is probably the most important, just that foresight and preparation.
Yeah, thanks for that. May, I wanted to ask you as well, in terms of the policy side of this, are policymakers, sorry, we're having some buzz on the line. Are different states thinking about, rules and regulations around how providers would be, certified or licensed to practice online? Is that coming up in any of these discussions? Again, not for the pandemic, but kind of post-pandemic.
So licensure has always been a significant issue with telehealth and a significant discussion point. I mentioned earlier that it's really within the states to decide on, how their licensure laws work. And then basically it was, you needed to get a license in every state that the patient's located in if you're providing services to them. And what we had pre-COVID-19 were ways to address that were through compacts, which was agreements. States would sign on to a compact and they would have a certain process to, either make it easier to practice in other states. So there's actually not a lot of specific laws on the books or policies on the books of like, having a telemedicine certificate or a telemedicine license in order to practice in another state. It's been sort of more like, how do we like remove those barriers as far as making it easier so you can go into other states to practice without having to go through the whole thing of like applying to the medical board to get a license and get approval and so forth. And that's been split. So there are some states where it is easier to do that, where they have joined a compact, and then other states, I'll give an example, my state, California, which is not a member of any existing compact out there and has been very, reluctant to join some of those the compacts, or even like hold a discussion about that, where you have other states who are involved in multiple compacts. That's going to remain, I think, like a major discussion point, especially where telehealth is concerned, regarding, do we want to leave it still to like states to regulate that? And there's like good reasons for that. And then there's other reasons of, maybe it should be a little bit broader, or like some of that should be relaxed, such as sort of, like I have a driver's license in California, but I'm allowed to like, drive in other states as well. Should it be something, we have policies similar to that where it gives you some allowance to do that. I think this COVID-19 crisis, again, it shined a lot of light into the problems we have in our healthcare system, not just with telehealth, but with like a lot of issues that we have. And it was very clear we were not quite ready. And when I say we, I mean the overall system. Some states were like maybe I think a little bit better positioned than others where telehealth was concerned to like integrate the technology in delivering care. There was really kind of a scramble for it. So I think all of these issues are going to become like major talking points once we get past the initial crisis. And they're going to be more thoroughly discussed than I think prior to COVID-19, where we thought we had the luxury of taking our time and discussing it more thoroughly. I think now it's like we've just experienced this and we're not ready. So what do we need to do now in order to like position ourselves with the policy to make sure we're ready before the next sort of big thing hits us?
I would just add on to that two things. One is that I think the whole notion of having telehealth baked into an emergency response is something that we're going to have to contemplate going forward, because there will be another pandemic. Mm-hmm. The other thing I would say is, in response to your question, Daniel, on certifying in telehealth, the way we talk about this is that telehealth is health. It's another modality of care. And as Angela mentioned, it's really up to the clinician as to whether or not they want to use it. and how they use it. I think that the best analogy I can give for your attendees is the immediate past president of the ATA, Andrew Watson, is a physician and a surgeon at UPMC. And he said, you know, when laparoscopic surgery was first introduced, we called it laparoscopic surgery, and now we just call it surgery. So we call it telehealth, but really it is health, and it's just another modality of providing care.
Thanks for that. I wanted to, Anne, stay with you for a minute and go back to the point that you had raised earlier about, you know, the questions about security of the technology being used, as well as the fact that HHS, you know, said that they would be using their discretion in enforcing the HIPAA privacy rules, you know, to encourage providers to, you know, not feel constrained in using different tools. Obviously, in the pandemic, I mean, we just want to see people connected, and we're trusting doctors to make good choices. But going forward, you know, what kind of flexibility do we need to give providers so that they can easily use the latest technology, and that so, you know, certification and security doesn't become a barrier, but we're still protecting people's, you know, very sensitive health information?
Right, and I think that it's safe to say that as a patient, you're incredibly concerned that your information is going to be treated with the utmost privacy in mind and confidentiality in mind. I think going forward, you know, once we work our way through this, our sense is that HHS envisions providers using non-HIPAA compliant technology in only the most extenuating circumstances. And it's the expectation then that certainly is not one of those regulations that's going to be that's not going to be rolled back. In fact, it will be rolled back. And so what we're doing is working actively with our members and the community at large to ensure that they know what is HIPAA compliant and what is not, so we can steer them as best as possible to those platforms that are most likely to be maintained going forward. I think the last thing anybody wants is a breach in confidentiality because of the use of some tool that may not have been anticipated, and then it reflects poorly on the entire industry. That nobody wants that to happen.
And right now, are there, I mean, a lot of the telehealth providers, I'm sorry, a lot of the healthcare providers that are going to be getting FCC funding to, you know, the $200 million that's been made available for transition to this. Are there any requirements there that they only procure, you know, HIPAA compliant or secure technology? Is there a risk that some of that money will be going towards, you know, technology that maybe isn't best suited for providing patient care?
Well, as I said at the onset, I'll let May answer some of those tricky, artful policy questions more directly.
Sure. May?
You know, I'll be honest, I'm not quite sure if they have that explicitly required, but as Anne has said, I mean, along with ATA, the telehealth resource centers have been encouraging and really stressing to providers, just continue as if those you don't have discretion, that nothing has been relaxed, because there are a lot of options out there. You should not have an issue in like being able to continue to meet compliance as if nothing has been relaxed. So that there really is no issue. We understand in that people are trying to do this very quickly. They're trying to ramp up quickly. As Anne said, somebody did it in 36 hours, but they are very easily able to find those types of technologies and do those processes in order for them to still ensure that there's health protections in place. And as Anne also mentioned, you know, that was just HIPAA. Even though the feds relaxed HIPAA, there's a lot of states out there that have like actually more stringent type of laws. So they had to do that anyway for the most part, because actually, you know, states have been relaxing it a little bit, but they haven't all been relaxing it. So depending on what states that they are going to operate on, they have to follow the state laws and regulations as well regarding protection of health information too.
Right, and the third-party agreements.
I would think too, for most providers, especially those who were not previously using a platform, the greater concern would probably just be a lack of understanding what those requirements actually are. I haven't heard of, you know, an issue with platforms being put forward that are, you know, purposely not meeting HIPAA compliance. It's more about the peripheral elements of it, which are things like firewalls and access to information and opening up, suspicious emails and all of these other components of security and privacy that I think overlap with HIPAA, but there's no like obvious or easy checklist for them. And so if you're a provider who's coming into this space and trying to do so quickly, in a good faith effort to play a helpful role in the pandemic, I think that's more likely where missteps are going to happen. It's because of the other interfaces with the actual telemedicine platform itself.
Yeah, that's a really good point, because underneath HIPAA, there's actually nothing specific to telehealth. So Angela's absolutely right. There's not like a checklist. Oh, if you do X, Y, and Z, you're perfectly fine. So they do kind of need to figure out on, okay, what is a platform that will help me meet HIPAA compliancy? So a platform is not going to make you HIPAA compliant. It will help you meet your HIPAA compliancy requirements, but it's just saying like, I get X, Y, and Z, I'm fine. It's like you need to do a whole bunch of other stuff in order to make sure you are still HIPAA compliant.
Mm-hmm.
So I want to shift the conversation in another direction. One of the questions that often comes up, of course, around moving things online is questions about the digital divide and disparate access to services. So to what extent are we seeing this in telehealth, in particular around different patient populations that might be significantly affected, whether it's rural versus urban, low income people with chronic health conditions, seniors living in assisted care facilities? Where are the main gaps right now, and what should be done to close those gaps or address those challenges?
Sort of your first gap was something I mentioned earlier, is in the digital divide, is like who actually has access to the thing that will allow you to connect with telehealth. I mean, that's why you're seeing so many policies where they're allowing phone, because technically for a lot of states, phone does not come underneath the definition of telehealth or telemedicine. They have in statute or within their Medicaid policies, usually actually an explicit exclusion for audio only or phone. So that's why you're seeing a lot of policies saying telehealth and phone, we're allowing that. Because if they just said telehealth, it would exclude phone. But policymakers recognize that not everybody has a laptop or a smartphone, and the only thing they may have is that phone in which they are able to reach somebody. When you're talking about rural areas, it may not only be like the technology and they're not able to access, but we haven't touched upon it, broadband connectivity. That's still been an issue. It's an issue pre-COVID-19. It is still an issue now because telehealth won't work if you can't connect. So people may only have that type of phone line for them available to receive services. Where, at least we've been talking to folks, where you are seeing sort of, people, communities that might be left out are possibly seniors, though not all. I mean, it varies. Rural communities because of the connectivity issue as well. And also maybe some minority communities who are not really familiar with telehealth or understand, or there may be some cultures that kind of view technology a little warily in like receiving their healthcare services. I can tell you right now, my parents, who you probably see my mother sort of walking around the background because I'm helping them through this, they fall into that category in that they're seniors who have medical conditions, and my mother had like her first telehealth visit last Friday. But she would not have been able to like utilize that technology unless I was there with her to like facilitate that for her. So what about those seniors who don't have like a family member or a caregiver who's able to do that for them? So they could possibly be left behind as well.
Mm-hmm. No, go ahead.
I was just gonna. We're experiencing the same reality as far as utilization in our senior and our rural population being significantly lower, mostly related to what you just described as far as access to broadband internet. I think the other community that I would make mention of is those with disabilities. I think that not only is access an issue with those communities, but also, are the telemedicine, telehealth platforms that are designed and more readily available right now, are they designed in such a way that is culturally sensitive to what a person with a disability would need to overcome in order to participate? And so I think that's another community that we're probably seeing, underutilization because we haven't structured the platforms in a way that can be meaningful for them.
And Angela, can I just ask you to expand on that point a little bit more? What kind of changes would that look like?
I think that again, it would be specific to each disabilities community and what their particular disability is. But I think just looking at any minority group in tradition, typically things are built and structured for the overwhelming majority. And so even looking at the size of font on a platform, or whether or not it can be utilized by someone who has a mechanical disability, say from an amputation, there's so many factors that play into engagement. And so when you're talking about models right now that are somewhat one size fits all, I think it's more difficult. There's at least an extra hurdle there for someone with a specific disability to find a platform that could be, again, complementary to their particular lifestyle.
I would just echo that and say that the notion of user-centered design is really lacking when it comes to disabled populations in general. But I would also add that what we're very concerned and focused on is the notion that there's going to be a huge surge in an uninsured population as well as Medicaid populations. And the Medicaid population generally has not been a big adopter of telehealth services. And we think that if you recognize that for many folks who are in Medicaid, their phone is their lifeline, it's how they get things done, that we have to, as a society, acknowledge and embrace that and allow people to get their health care that way as well. So I think that's something that we have to be aware of. As it relates to seniors, I think that there is one thing that we talk about is that with the pandemic, that regulations have finally caught up with what technology can do. And so with that, if you look at what's happening in skilled nursing facilities and nursing homes and how many limitations there were in terms of being able to use technology to treat these populations, reduce readmissions to hospitals, and really to ensure that people are taken care of in a safe way, again, we're seeing lots and lots of success stories there. And hopefully those are the kind of gains that we'll be able to cement going forward.
Thanks. So I want to encourage, again, anyone who's watching, you can submit questions on our website, ITIF.org. If you're watching on YouTube, there's a link that you can use that will enable you to submit questions. But I want to ask one last question before we turn to all the audience questions, and that's around the question of reimbursement, which just comes up again and again. There's obviously kind of different lines of thought. One, in the interim, of course, a lot of providers, as was mentioned earlier, are using telehealth to cover their costs. I mean, they still have office space, they still have their traditional costs, and they're they need the full reimbursement to be able to continue to maintain their practices. Long term, I guess the question is, what will that look like? Will telehealth be an opportunity to increase efficiency in the provision of healthcare services? Should we be seeing lower payments for different types of telehealth services? What should that look like? And so maybe Angela, we can go with you first, and then I'd like to hear from everyone on this one.
Yeah, I think I would say that the reimbursement challenge has been one of the biggest reasons that before coronavirus, some providers were hesitant to dive deeper. I think at the end of the day, like you said, while everybody wants to play a role in being helpful, whether it's in the setting of a pandemic or otherwise, providers have to be able to cover their costs. They have to be able to, be paid a fair wage for the work that they're providing. I think, I've seen a lot of policy change, and maybe I'll speak to this more eloquently, but from CMS regarding, just what is being accepted. And I think it has been a huge driver for providers to at least be open to taking that initial step. And I think that will probably continue well beyond coronavirus for the reasons that we've all said today.
Mm-hmm.
Yeah. Any thoughts, Anne or me?
I've heard providers argue both sides. So I've heard providers saying it should be the same amount, whether I did it in person or via telehealth, because I'm using the same knowledge that I have if I had delivered the service in person. And also, again, they are viewing telehealth. It's just another tool, a way of me delivering care. It's not something different. So why wouldn't I be paid the same amount? And then I've had other providers say, well, but my overhead might be less when I'm using telehealth, so I probably shouldn't be getting as much money as I would have had it been done in person. I think right now, initially in the beginning, if you are paying less for telehealth, that acts as a discouragement to use it then. Especially pre-COVID-19, if they were getting less for a telehealth interaction, the question is, then why am I bothering using the technology when I can see somebody in person? This COVID-19 has really changed the discussion on that. I think that now that we have this pandemic and that, people are staying in place and that telehealth has become a lifeline to a lot of practices, there may be some shifting of opinions in what we should be doing as far as, parity of reimbursement. So I think there's just like a lot of things that are out there that we're going to have like these serious in-depth discussions, and we may have like opinions that were one thing pre-COVID-19 that have now shifted now post-COVID-19, hopefully when we get to post-COVID-19.
Yeah, when we.
I think one other thing on parity, I think that's the perfect word. When you think about parity, I think we often think about value, right? So you're looking at something, and if the value is equal, then it should be reimbursed equally. And so I think there will be conditions, there will be particular circumstances where, again, an in-person evaluation, a particular piece of equipment, something about that encounter, there was more value delivered, say in one environment or the other, whether that be the telehealth environment or the in-person environment. And I think that's what's difficult, is coming up with a very clear formula of how to measure value. I think if we were able to define that, then we would be able to say, exactly how both telehealth and in-person encounters should be reimbursed.
But I also think that what gets lost in this a little bit is the problem that existed pre-COVID, which was there was insufficient access to clinicians. There were not enough clinicians to take care of our population that's aging, that has multiple chronic conditions. So that is the fundamental, and that didn't get any better with COVID. In fact, it got worse. So I think we really have to go back to this notion that the technology can be used to reimagine care, that if we use it to replace a face-to-face visit with a phone-to-face visit, it's not going to answer the problem that we have as a society. It's not going to address the issue. So that's really fundamentally where we have to go.
So one of the questions, we've seen that actually a couple of questions along this line, is around remote patient monitoring and its use. So, what role do you see remote patient monitoring to have in kind of a telehealth space? And related to that, there's also a question about what efforts are being created what efforts are there being made to create standards for connected devices, the Internet of Things, to be used with telehealth?
Well, I'll address the remote monitoring, which has been phenomenal. I mean, in terms of the value it's provided to make sure that people who can stay in place are able to stay in place with the oversight of their clinician. It's also augmenting a lot of tools and resources, AI, machine learning, to be able to monitor signals so that a clinician is able to determine whether or not someone is, their systems are going south before they actually happen. So I think this idea that the technology is evolving very quickly is one that we're seeing with remote monitoring. And there's so many use cases now where you keep hypertensive moms, safe at home, postpartum, where you're being able to use it to treat people with diabetes. It's being used for patients with congestive heart failure. It's just over and over and over again. So I think remote monitoring and having organizations like Best Buy, for example, get into the aging in place, it just speaks to the fact that this is not going away. It's only getting bigger.
But yeah, I've never understood why the policies for remote monitoring have not been as extensive as they've been, because there's actually quite a lot of evidence in like the efficacy of it and like how well it does, and also some of the cost savings that it can achieve for health systems. So I've always been a little confused as why there hasn't been more with remote monitoring, at least on the policy end, and allowing that and reimbursing for that. With your second part of your question, just a little bit of clarity, they're asking about like standards for the technology or in how to use the technology.
Yeah, they're asking, are there efforts being made to create standards for Internet of Things capabilities or tools for use in telehealth? So I would guess that could include plugging into electronic health records, developing standard modes of practice on how to use the information. We've seen, of course, a lot of news about smart thermostats even, and how that's been used for disease surveillance.
Yeah, that's always been a question. So, way back, it's only a couple of years, but way back when they were integrating or starting to do like, having people do electronic health records, telehealth was left out. I mean, it was kind of like operating on a parallel track. So there wasn't like a concerted effort in like, how do you integrate when you're doing telehealth? How do you integrate that information? So what you've seen, at least from my experience in talking with people and like different health systems, is like they've kind of, each entity has kind of done their own thing of like built their own bridge or like worked with programmers to build their own bridge to like have that telehealth information put into the EHR. Is there like a movement to try to standardize that a bit more in what they're doing? I haven't really heard. I mean, Anne, maybe you have, but I haven't really heard sort of like a specific telehealth wave of like trying to do that. I think people, and that's kind of been the thing with telehealth, is that a lot of times you just have an organization, they just try to figure out, because the policy may not be there or it's been vague, and they've just tried to figure out a system of like how best to do it themselves. Is that going to change now with COVID-19? A lot more people using telehealth? Probably. There'll probably be like a lot more sort of direction in how to do that, instead of like, just having, this organization here and there, or like trying to figure it out on their own.
Right. And I would just say that pre-COVID, this notion of telehealth interoperability was an issue that was really frustrating for clinicians and really hampered some adoption of it. And many solution providers, as May alluded to, really sort of took it by the bull by the horns and wrestled their way through creating some integration. I think we'll see a lot more attention to that going forward.
Mm-hmm.
There was a pair of questions that came in asking what U.S. telehealth practices should be adopted in other countries, as well as the converse of that question, what telehealth practices from other countries should the U.S. be looking to adopt? Any thoughts on that?
Well, we had a conversation a few weeks ago with our partners, ECH Alliance, and talked about lessons that they had learned. I think that one of the practices that they used was just the whole notion of breaking away from, it as a necessity, using things like WhatsApp just to get decision making done very quickly amongst clinicians, and adopting that very, very fast. I think we're going to start seeing more interchange between what's happening in Europe and Africa and Asia and the US. But I would say that two observations, again, pre-pandemic. One is that most populations are aging and there's an insufficient workforce to deal with that population. And then the second is, in light of those shortages, the response of a country is going to reflect their values and their culture. So you see a lot of countries that obviously have gone to social welfare systems, health systems that are more value-based or more encompassing in their approach, as opposed to a fee-for-service model. So that may be, some of the distinctions that we see worldwide.
We're also seeing, I think, some commonalities as well, because it's so funny that question was asked, because I was just dealing with some questions from South Korea last night. And one of their questions was, how did the US convince providers to do this? Because we're having a hard time in South Korea convincing providers to use telehealth. So I think we're seeing commonalities of like, what you run into in other countries as well. It's like, providers don't want to do this, and I kind of understand that. I'm a creature of habit myself. We all get into, doing things a certain way, and it's kind of hard for us to like go to something new. And I think, that's one of the things, is that what you're seeing in other countries, you see in the US as well, is that provider reluctance, because they've been taught to deliver healthcare in a certain way. They've been doing it for so long this way, so it's really hard for them to break out of that habit and like do it a different way.
I think it will be interesting to see within those different cultures, within different countries, the role of the patient as a consumer. And so, Anne, as you alluded to before, Best Buy stepping in and now having direct-to-consumer, a direct-to-consumer offering that puts it on the forefront of the patient's mind about things like remote monitoring. I think that will really fluctuate quite a bit, when you look at different cultures and whether or not healthcare is seen, again, as a consumer product, the way that some other industries are. So that's a little bit interesting.
But I think, in Africa, for example, the phone is the most pervasive, dominant mode of communication. And a lot is done with the phone in currency and payment systems, in healthcare. So I think that, given that reliance and interaction with those types of services, it is very different. And we could learn quite a bit from them from a consumer standpoint as well, I think.
So another question that came in was asking if someone would please address the question about therapy services, such as speech and occupational therapy, and the ability to provide those via telehealth, in particular for developmentally disabled adults.
Yeah, allied health professionals, as far as the policy, and they're kind of like overlooked a lot, in that they're not, for a lot of payers, they're not eligible with telehealth providers. In Medicare, they're not. So they will not pay PTs and OTs and speech language pathologists underneath the Medicare program if they deliver a service via telehealth. I know there's been a lot of interest in that and allowing that, and you definitely need that during this pandemic where people can't make their appointments with their therapist, or the therapist can't go to somebody's homes. The states are a little bit more all over the place. Some of them allow it, some of them don't. Some of them made specific allowances for them during this pandemic, but they are really like an overlooked grouping of healthcare providers with a lot of existing telehealth policy for reimbursement.
Thanks. And then the last question I have is really kind of a question asking about the future of how, I guess, healthcare might be provided. And the question is really, post-crisis, are insurers going to start using virtual networks of providers rather than sending patients to their traditional local doctor? Are we going to see a shift in that? I know when I recently used a telehealth service, I was just seeing my regular doctor, kind of creature of habit. But in theory, there might have been a more efficient way of allocating services there.
Angela?
I was gonna say, I think we've seen it pre-COVID that lots of insurers are looking to partner with networks of remote clinicians. They're offering a telehealth benefit. I think there's no reason to believe that it won't continue to grow. And those networks are interchangeable, or at least they can collaborate and exist, together, in that perhaps your very local primary doctor doesn't have availability either during the day or after hours on a weekend. You might be seeing someone who is in this, secondary, if you will, clinical network, but then they're planting, the relationship you have with your primary home. They're there as an adjunct. They're there in a support capacity, and then able to relay all of that very valuable information right back to your primary, doctor. And so I think you will definitely start to see insurers building those networks, not necessarily to replace what's already in existence, but again, to act in tandem.
Well, thank you for those comments. Thanks to all three of you for being with us today. I think this is obviously a very important conversation. It affects people's lives. It affects the kind of future of the healthcare system. I know Congress is thinking a lot about these issues, and I know you're all excellent resources as they're moving forward with their questions about how to address these types of challenges. So thanks again for joining us today, and thanks to our participants.
Thank you.
Thank you.
Thank you.